All right, now we are
Okay.
recording.
It's recording. So we just wait for a few minutes just to see if anyone can join. And then we start. Sophie, if you want to start sharing your slides.
Yes, I'm searching for you. There we go.
Katja.
Now you see my home screen.
See that? Yes.
Hello.
Yes.
Katia.
Hi, hello, everybody. Hello, thank you very much.
Okay. Okay. Ciao, Mirka. We'll just wait 2 minutes.
So shall we start or?
Yes, I think we have waited for, I think someone will join during the webinar, but anyway, welcome to this third webinar organized by our organization Sanfilippo Fighters in collaboration with MetabERN on how to recognize and manage urgent and emergency situation in Sanfilippo syndrome and related diseases. I would like to thank our speaker for today, Sophie and Nolanda, for joining us and talking about feeding and nutrition emergency in Sanfilippo syndrome and related diseases. We can start with Sophie's presentation. At the end of the presentation, there will be time for question. And if you don't have question right now, you can write us your question later, and we will do our best to answer your question. So this webinar is going to be recorded for educational purposes. It will be shared on Sanfilippo Fighters channels. So just to let you know, and I think we can start. So Sofie, the stage is yours. Thank you.
Okay, thank you, and good evening, everyone. So this evening I will talk about feeding and its difficulties in Sanfilippo syndrome and related diseases. So first, after a short introduction, I will talk about Sanfilippo and its feeding difficulties, dysphagia, the clinical investigation we can do, diagnostics we can use, and I end with cases, and of course there is room for questions. So first I would like to introduce myself. I'm Sofie Cocquyt. I work as a speech language pathologist, logopedist, as we say. I'm also a deglutologist and since last year also a lactation consultant. So my core business is really feeding difficulties. I work in the University Hospital of Antwerp on the pediatric neurology, but also on general pediatrics neurology, and also in the Center for Developmental Disabilities. So I have a very wide variety of children with feeding and communication challenges. So it's not really specific, the Sanfilippo population, but the approach is very similar as other patients with neurodegenerative or other syndromes. So I think Sanfilippo, you are all more experts in the definition of it, so I leave that for you. But when we see it in the field of speech therapy, we see that these patients have slower or disturbed speech development, which I will not tackle today, but they also can show the swallowing difficulties, which we call dysphagia. And since there is no treatment for Sanfilippo, we have to manage the symptoms. Since each patient is also unique and shows specific symptoms, we have to treat the patient. We must therefore look at the specific needs of each patient. So there is no general or standard treatment. We can say this you should do for Sanfilippo patient. No, it's really you have to see, okay, what does this patient need? And it's also very depending on in which state of the disease they are and when do the symptoms appear. Is it early or later in their life, and how severe, of course, are the symptoms? So if we see a dysphagia, what is actually dysphagia? Dysphagia is a medical term for difficulty of swallowing, and it can affect any part of the swallowing process. So it can go from the mouth to the esophagus, and people with dysphagia may experience or pain while swallowing. It can that they feel as if food is stuck in their throat or chest, or they have frequent coughing or choking events during meals, and this condition can lead to complications such as malnutrition, dehydration, and aspiration pneumonia. What do we see from dysphagia in the Sanfilippo population? So we see that these patients can have swallowing difficulties, as definitely as the disease progresses, individuals may struggle to swallow food and liquids safely. Then they also can lose the ability to chew efficiently. So hard chunks will get more hard to chew in an effective way. They also can have an enlarged tongue, which can cause drooling and also make it more difficult to keep the food or the liquids in the mouth. They have a higher risk of aspiration of food and liquids, so that means that the food or liquids is entering the lungs, which can lead to aspiration pneumonia. There is also the choking hazard, so due to difficulty in the coordination, they can choke, and this of course makes the mealtime stressful and more dangerous, but not only for the Sanfilippo patient, but also for their caregivers and environment. And then we have, of course, the nutritional challenges. They can lead to poor nutrition, weight loss, as the individual has difficulties or discomforts due to eating. So what do we use for some kind of classification. First, we have to look at their gross motor function, because we know that the more their motor function is complicated or disturbed, the severe their swallowing function also can be disturbed. So, for example, this is the gross motor function classification system, and we see patients with, for example, level 5, so that means that they have to be transported in a wheelchair. They have more severe dysphagia. So, for example, when we talk about the dysphagia limit, that is the amount of food they can swallow safely in one time, in one swallow. For patients at level 5, they can only swallow a small amount safely, compared to the patients that are the GMF TS level 1, for example. They can swallow a bigger bolus in one time safely. So there is this correlation between their overall motor function and the dysphagia. For the eating, we use the eating and drinking ability classification scale. It's not a diagnostical tool, but is a systematic method for describing the eating and drinking behavior of people with cerebral palsy. So it's not made for patients with Sanfilippo, but we use it for all our patients with neurological and degenerative diseases, since they have a bit the same approach we use. So it consists of 5 different skill levels, and it can be used from children starting from years of 3 age, but there's also an EDAX mini for the smaller ones. And the objective is to determine the level that is most closely matches to their current skills and or limitations. And EDAX is built around safety and effectiveness. So safety stands for the risk of aspiration and penetration and choking, and effectiveness is the time and the effort the patient needs to eat and drink and can control their mouth area. And it's also supplemented with an indication regarding independence. So if we look at the main question, we have to ask ourselves, is the individual able to swallow food and drink without risk of aspiration? So if the answer is yes, then we ask ourselves the question, is the individual able to bite and chew on hard lumps of food without choking? If that's also the case, then it's just a matter of time. So then you end up in level 1 or 2. So level 1, they eat almost normal, and level 2, they eat and drink safely, but with some limitations to efficiency. When the patient is not able to chew on lumps or foods without choking, they end up in level 3. When we go above again and we ask, so the answer is no on the question, is the individual able to swallow food and drink without risk of aspiration? So then we ask ourselves the question, can the risk of aspiration be managed to eliminate harm to the individual? Depending on the answer, we end up in level 4 or 5. And in level 5, we say, okay, the patient is unable to eat or drink safely, and tube feeding must be considered to provide nutrition. So for us, it's a very useful tool also to evaluate the patients in time and to see whether they shift from one level to the other over time. And also because in Sanfilippo syndrome, respiratory complications such as pneumonia have been reported as the primary cause of death, it's very important for a routine screening of the swallowing function in all patients with Sanfilippo. We would do it yearly, but if patients report feeding difficulties, we see these patients more often. Then there are other comorbidities we have to keep in mind. These patients can tackle visual disturbances, and when you don't see the food you're having, or you don't see good at all, that also impacts your eating behavior. Then they also have the pain issue, these patients. Yeah, of course, when you're in pain, you're not feeling comfortable, so you're not eating the same as you would not be in pain. Then we have the cognitive deterioration, which also gives an impact, of course, and the behavioral problems like when you cannot really talk to them or explain them what's important, that can have also a big impact on the eating situation. And then we have the communication challenges as well. If the patient is not able to say anymore what they want to eat or what they like to eat, this can also impact the eating behavior of the child. Then it's important to do a severe, thorough dysphagia examination, and it starts with a good anamnesis. So we ask the patient, if possible, or their parents or caregivers or someone, a teacher from their class. That's also important and interesting to have information from several perspectives, because at home it can be completely different than at school or somewhere they're staying. So what do we want to know? Is the patient choking or coughing a lot while eating? We ask for respiratory problems. For example, are there reactive airway infections? Are there recurrent pneumonias? Are there febrile episodes without apparent cause? These things. Then we also want to know the duration of the meal times. Are they taking more than 30 minutes in time? Because we set 30 minutes as the maximum. Otherwise, it gives a big burden on their quality of life, and not only of them, but patients that have to eat more than an hour. It's also it gives a big burden for their environment as well. But that's also very depending on how the parents or the environment perceive the situation. Some of them really don't mind to sit at the table with their child for 1 hour. Others think it's the end of the world. Then we, of course, want to know how diverse or varied is their diet. It's important for us, even though we're not a dietitian, but we want to know that they're eating that they're not, for example, only drinking milk, but they can also eat vegetables and fish and fruits, etc. We also ask about stress experience at mealtimes, not only by the patient, but also by their environment. And then we look at evaluation on weight and growth, their curve. And then we ask about teeth brushing, because we know when patients have good oral hygiene and then aspiration occurs, they will inhale and aspirate fewer bacteria. So they have less chance on developing a severe aspiration pneumonia. So that's why it's really important that teeth brushing is done frequently and effectively. This is often difficult because the patients, they don't really like it, and they can become very stubborn, or they don't want it to happen. So then a 3-sided toothbrush sometimes can help, because if you, for example, if the patient or the child lets you with the toothbrush in his mouth for only 10 seconds, and then you can brush with this special toothbrush, you can brush already a little bit more than you would have done with a normal toothbrush. Then what's also important to have a good meal observation. So when the patients come here, they take something to eat and to drink, and we really want to observe all different consistencies that the patient eats or drinks. So we want to see liquids, soft food like purees, but also hard food where we can elevate their chewing abilities. And then we evaluate the safety, the effectiveness, the posture of the caregiver and the child, the equipment they use, the consistency of the food, and the salivation. If there is a problem, we try to locate it from the outside at the time of the consultation, and there can be at 3 sites a problem. If it's an oral phase problem, here food is collected into a bolus in the mouth to be transported to the throat or the oral pharynx. But due to coordination problems or intraoral sensitivity problems, these children are sometimes not able to manipulate the food effectively and safely in the mouth with which can result in delayed swallowing initiation or incomplete or delayed transport of the bolus from the mouth to the pharynx, or there can even be leakage over the base of the tongue into the oropharynx. So that means the child has his food in the mouth, but even before it's swallowed, the food is already going down to his throat. So the child can choke before it actively swallows. So that can be an oral phase issue. If we talk about pharyngeal phase, there the food is swallowed while the airway must be protected. But various structures must work together quickly, like there must be velum elevation, laryngeal elevation, epiglottic descent, vocal cord, vocal fold closure, and opening of the upper esophageal sphincter for the food that can be transported smoothly to the esophagus. But as you hear, there are a lot of things that has to work together, so a lot can go wrong, and that can lead to the pharyngeal swallowing disorders, such as laryngeal penetration. That means that there is food up to the level of the vocal folds, but it's not passing them, or aspiration. So food that is passing the vocal fold, so entering our airway, and this can be with or without cough reaction. So sometimes patients have food entering their airway. We, without any disease, we would cough extremely, but sometimes the sensibility is disturbed, so they don't feel it, and the food is just dripping into the airway without cough reaction. But that we cannot see from the outside, of course. And then the esophageal phase of swallowing, there the food is moved through the esophagus into the stomach, and disturbance includes mobility problems and gastroesophageal reflux, also things that we see in this population. At that time of our meal observation, we can also make some adjustments, like the position, as I spoke. So we see a lot of these patients with their coordination is not as good as before, and a lot of them are eating in this position. But this way, also due to gravity, the food is falling quite quick into the throat, so they need a quick swallowing reflex, which is often not the case. So we always advise to do a chin tuck. So that literally means we tuck the chin in like this. And this gives a better protection of the airways. Yeah, it's because of the epiglottis, so there is a reduced risk of aspiration, there is an improved swallowing reflex, and there is also better control of the food bolus towards the esophagus instead of to the airway. I will show that later in one of the cases. Then we can also immediately give advices about materials, like a smaller spoon or an adjusted cup, I will show you. And we give advice about consistency and bolus size. By bolus, I mean the amount of food they give at one time. If we are not sure, we cannot see it from the outside what is happening inside, and there are some red flags, and we think, okay, we have to look at it closer. We can do instrumental studies. You can do a FEES, a fiber endoscopic evaluation of swallowing. But it's not very easy because the patient has to listen, has to follow up instructions. A fiber is put in the nose, and they look to the larynx when the patient is swallowing, but at the time of the swallow, you don't see anything. So it's not really easy, but luckily we have something else, and it's on radiology, an RX swallow, as we call it. So it's a video fluoroscopic swallowing study, and you get dynamic radiographic images. It also has its limitations or difficulties. For example, the patient has to swallow a contrast fluid, which is, we use iomeron or barium, but the taste is really not nice. So the patient in that way is not swallowing as they would swallow their normal food they're used to. So that always gives an extra challenge. We make images from the front and lateral, and then during that investigation, we evaluate the adaptations we can do. For example, if the patient is used to eat like this, then we can see, okay, what's the difference if the patient is eating like this? Is it more safe? What's the difference if we give thicker consistency? Is it more safe? So it's very important for us as a speech language pathologist to be present at the time of the video fluoroscopy, to give instructions to the radiologist and see what do we actually want to know. If I speak about consistency, we always use the ITSI guidelines. ITSI is an international dysphagia diet standardization initiative, and it has 7 levels of thickness. So we start with just 0, and it's just like water, and then we build up slightly thick, it's ITSI 1, to extremely thick, for example, a thick vegetable puree, and level 7 is easy to chew foods. To go from 0, for example, the water, to make it a little bit more thick, we use the thicken up shell and the Nutrillis powder, as you can see here. It's very easy in use, especially the thicken up shell. It can stand, it has no taste, it doesn't change over time, so it's a really useful product. Then other management strategies, except for modifying our diet and thickening the liquids, we often advise to provide more soft purees or soft foods that are easier to eat, instead of, for example, like real pieces or lumps of food, as chewing and mastication gets more hard. About thickening the liquids, it's safer because the flow is more slow. So the patient has really more time to swallow. And when you thicken the liquids, the bolus becomes more homogeneous. So you will see that in my case, it sticks better together. So there is less spilling when the food is in the mouth. There is not something that's already passing through into the throat. And we also advise to avoid different consistencies like cornflakes or soup with chunks, because the different consistencies in the mouth can be confusing and difficult to swallow safely. We also can advise the way the food is suffered. For example, parents or caregivers, they think, okay, I give a big spoon because this way it will go faster. But as I told before, when their global motor skills are deteriorating, we see that they are also in their mouth, they have more difficulty in taking bigger sizes. And so often we advise to use a smaller spoon with only a little bit on the spoon. That's more safe to swallow. Also, when drinking from a cup, as you can see here, the little child with the white or red cup, this is a special cup where we can have the chin tuck compared to a normal cup. When the patient is drinking, they do like this, and that is not the case with these special formed cups. For babies, often parents, they make the teeth of the bottle bigger, and that's also really not what we want. It's not safe. Patients, so the baby bottle, we really advise to use a bigger teeth, but not to make the teeth the hole bigger with a knife or something. Then the postural changes I talked before, so the chin tuck, and of course we advise to not eat and drink while walking, because a lot of children do that, but we see, of course, that it's not safe. And then in the end, if it's all not enough, our modifications, then we advise tube feeding. It can be with a nasogastric tube or a gastrostomy tube when we think it's more for a longer time. Then we advise the gastrostomy tube, because the nasogastric tubes, a lot of patients, of course, they pull it out, and then we have to replace. Then it's really a negative experience. But the gastrostomy tube, it's also an operation, so we have to also really consider it thoroughly and talk with the parents, because it's psychologically often a big step for them to make.
Of course, but can I say something to it?
Yeah,
For
sure.
me as a dietitian, I see a lot of problems because a lot of patients get really long time now to get your tube, and then we see that they have a lot of feeding problems afterwards for years and years and years till adulthood. So ACFID is an eating disorder, and most of the times the reason because of this is autism or a nasogastric tube after the age of 6 months.
Mm-hmm.
So for me, I prefer as a dietitian the gastrostomy.
Yeah, I totally agree. Yeah. An nasogastric tube can be useful, for example, a child that has a virus and stops eating and drinking, so for a week or two they need it. But indeed, the gastrostomy tube is really our preference. Yeah, sure, definitely. Then I will show some examples from our diagnostics. So here you see a patient with severe syndrome, and we give him on the radiology ITSI-3. So it's moderately thick. And you see here, this is the airway, and you see this little white stripe here. It is the fluid that's entering his lungs, but he's not choking at all. You see also that the mother has to help him to move his mouth, so he's not eating efficiently at all. He has a PEG tube, I guess, yeah. And then we have offered him ITSI-4, so it's extremely thick. You see already in the mouth, the bolus stays better together, so there is no leakage here. And if he swallows, the bolus sticks better together. Takes a long time before he swallows. But you see, it's staying better together. So if he swallows everything into the esophagus and not into the airway. So it's just a little adjustment that can make a difference between aspiration or not. And here I show you a difference in posture. So this child is having normal liquids. I show you again. If watch closely the airway, there you go. It's just entering the airway in a big quantity, and the patient is not swallowing at all. You see, show you again. Here, this is just contrast going into the trachea, and the patient is not choking at all. Then what we did, we positioned him better, that he's more chin tuck. It's not thickened the fluid, so it's the same. You see immediately there is better oral control. It's staying better together, and it's not already leaking into his throat. And this way, this child was not aspirating in this position, but of course you cannot always observe a child while eating and drinking when they're at school. So also for this patient, we advised anyhow to thicken the liquids to avoid aspiration. So if we want to decide if feeding is safe in patients with Sanfilippo and other related diseases, it's really a multifactorial decision we have to make. So we have to talk and think about the feasibility of adequate nutrition by mouth. It has to be safe, of course. We don't want the patient to aspirate while eating or drinking. We must also keep in mind we can advise to make adjustments, but they have to be possible and feasible for the parents and for the environment. For example, the caregiver, if they're not able to make the adjustment, yeah, it's no use. And then the parental perception, by that I mean some parents, they can do really big efforts to make it work, but it's not possible for all parents and caregivers. So it's also depending on the question and the question of the parent and how much help they need and how much they can take. Of course, there has to be a balanced diet, and their weight and growth curve has to be sufficient enough. So thank you for your attention. If there are any questions, I would like to try and answer them.
Thank you very much, Sofie. It was a wonderful presentation, amazing videos. Thank you very much, because it really gives us a practical point of view on the problem. If there are any questions, otherwise I have a quick question and then we can go on. Okay, so I have a question. I know a little girl with the rare disease, which is not Sanfilippo, and I often see her while she's eating, and she often coughs during eating and goes through vomiting quite often. And every time I ask her mother, the mum keeps saying, oh, it's because she has mucus, because she has cold. Yeah. But she also has severe reflux. So I believe the mucus may come from the reflux more than from cold. She's also she's been under chemotherapy for a few years, so her bone marrow is still recovering. So do you think that actually, for example, by handling the reflux, she may improve in her ability in swallowing? Are they linked?
So in this case, first, I really want to know if she's having a lot of pulmonary problems, respiratory issues.
No.
No. Okay. So yeah, then it's really useful to treat the reflux by also tickling it, I would say.
Okay. So
but it's really more for a gastroenterologist, I think.
Yeah.
Okay.
So because a lot of people think to give medication for reflux, but what we really know is when children get medication for reflux, they have more allergies, food allergies, but also other allergies. So for me, if there is a lot of reflux, please ask the mother to go to the speech language therapist to look with her because the coughing is make her tired, and then she cannot concentrate at school. So maybe that could be then a trigger point for the mother to have a conversation with the speech language therapist.
Okay. And one thing I forgot to tell is that when she goes through vomiting, she vomits from the nose.
Yeah.
Also.
Yeah, velopharyngeal insufficiency. That are all things we could see on the video fluoroscopy video. So that would be very interesting to do. Sometimes something, it can also be behavioral.
Okay.
So then it's useful to see a psychologist.
Okay. Oh, she can't speak.
Oh yeah. But then the reaction of the parents can sometimes.
Okay.
Yeah, so sometimes children will vomit just to have some attention, for example. Especially children with lower cognitive abilities.
Okay. Thank you very much.
Also children with an oncology past, because when they were in the hospital, they were very cured and everybody was giving them attention. So this could be, but my advice is to really talk to the parents and first go to the speech language therapist. If she says there's no problem, then you can go to the psychologist.
Okay, thank you. Katja?
Hi, I'm a Sanfilippo mom, and Francesco is nearly 12. He doesn't chew that much. He swallows quite well. I mean, he can eat almost all food, but Sanfilippo children usually are very hungry. They really want to eat all the time and in quantity, because I need to be quick to give him to eat, because he's always, asking me. I help him, because otherwise he would just, put all the food in his mouth. But do they? Well, he is a big boy, but he's not fat. But do they need? Because I think he eats so much. But do they need more food? Is Sanfilippo children metabolisms kind of different? Why do they always want to eat?
I think, Nolanda, you can answer this better.
So because you see over day, because of his restlessness, he is running and doing. Most of the children have a higher energy need.
Right. Okay.
And what you can do is give him a lot of vegetables, because vegetables are good also for the gut. Because I will come that to in my presentation, because diarrhea and constipation are often seen in children with Sanfilippo, but because of his restlessness and also in his eating, you see also restlessness. So give him then a lot of fibers in vegetables, then so then he can have enough to eat. So this is then he is happy. But if you give him, for example, a lot of desserts, then he become obese when he is 18, 19. So my answer is yes, it is normal for children in Sanfilippo that they have higher energy needs, but tackle this with vegetables, cooked or raw.
Okay, thank you.
Okay, so if there are no more questions, Nolanda, you can start with your presentation. Sofie, if you could just stop your sharing.
I'm looking for it, but I don't.
Okay.
Okay.
Good evening, everybody. I'm Nolanda van Wel. I'm a dietitian. I worked for more than 15 years in a mental disabled center with more than 5,000 patients with me. I had 6 patients with Sanfilippo at that center. And now for 7 years, almost 8 years, I work with Nestle Health Science. They asked if I want to come to work with them because they want to have some expertise in children and adults with neurological diseases to develop new kind of food for these children and adults. Now my presentation. This is my agenda. The nutrition policy, multiple feeding problems, nutrition is a challenge, malnutrition, the consequences are bigger than you think, and detecting malnutrition. Because malnutrition is everybody talk about obesitas, but if you have less weight, the chance that when you have a pneumonia and you have that there will be complications are much higher when you are malnourished. So, but if we talk about food, you see it as a multi-stakeholder ecosystem. It's not only the patient, but also the family, but also the caregivers around them. Then you see the HCPs and the medical center. Everybody knows a lot about feeding. And this is also why there are a lot of problems. Therefore, there are also KOLs, they make guidelines like the government. So you see, if there is a neurological problem like Sanfilippo, everybody has an opinion about it. So what we do, we say in nutrition about Sanfilippo, refer always to a dietitian when nutritional and weight problems occur. So the problem with you are, my son eat too much, and if you want to have some questions, please ask your doctor to go to the dietitian. But weight loss, stunted growth, or of declining in chewing and swallowing function, then you see that because of they have a lot of movements, they need more calories than normal. So as Sofie already said, is a speech language therapist. If you see problems, please go to her. She is really the specialist in it. Treat defecation problems to prevent leading. Because if you have a full tummy, you can't sleep, and then you are tired, and then you have behavioral problems. But also, if you have a lot of gut problems, so there's a lot of poop in your gut, then it's painful. And you don't have a lot of eating sense, but also because this is needing water. You see dehydration problems, but also malnutrition. So it's a circle you really should come out. What we also see in children with Sanfilippo syndrome is reflux. And reflux, this could also sleep and behavior problems because children, when they are older than 6 or 10, the speech is going down, and they can't say what is happening, and it's very painful reflux. So that's why they can have sleep and behavior problems. So that's the diarrhea and the constipation. But also what we also want to do is, as a dietitian, is see what the liver enzymes do, because if they are too high, we see a lot of problems. Okay. Sorry. Yeah. So Sanfilippo syndrome has multiple feeding problems. So the colic pain and the gastrointestinal discomfort, the enlarged liver, and sometimes enlarged spleen. Because they are so big, they go into the gut, and then you have a chance that there is constipation, because the gut cannot easily move. Diarrhea is a lot of times we see that a lot, and this is about the hyperencephat, and that is because the body is how can I say that? So it's because then when the heparin is so much sulfate is in the body, a lot of water is needed to that the heparin sulfate is go out to the body, and all that will go to the gut, and that's why the diarrhea occurs. Constipation, that's most of the time in old age, because they are no longer running, but have more sedentary living, and most of them sitting then in a wheelchair, and then you see when they are in a wheelchair, the bowel movements are less shorter. But I just talked also about reflux. But for me, reflux should be, you should go to the doctor, because reflux, it comes in the esophagus, and what you then see is that there are some problems there. And then what we see is that so cancer can occur then in the esophagus. So reflux, you really should go to the doctor with it.
Yes, can I ask something about diarrhea and constipation?
Yes.
Sometimes our kids can be regular, even, maybe, no diarrhea, but not that hard, but anyway, regular, like going every day. But and it can happen, out of the sudden, that for 1 week, 2 weeks, I don't know, they just kind of go to constipation, and they the faces are so hard. It is really difficult for them to evacuate. So but it's not like because no nutrition, no food, habits changes, no medication changes. It does happen sometimes. Do you think is something? It might be neurological or other.
No, I think it's with the heparin sulfate. So this is the liver.
Okay.
And what you can do then is, so my tip for the eating, giving a lot of fibers is really good to do. But what also good to know is because of the Sanfilippo syndrome, I always say normally a normal child 1 liter. So it's age plus 6 kilocalories, so 1 liter 1250. There are some advices for that, but for Sanfilippo, please use half a liter more than a child of his age should be.
Okay.
Water, soup, it doesn't make, but he needs to drink more. So what we see is, and I already said, we see a lot of constipation. So for me, the 1, the 2, the 3, these are constipation. And the 5, the 6, and the 7, they are for me diarrhea. And only the 4 is the good one. Because this is soft. But what sometimes occurs is that you see type 1 with type 7. And this for me is something, then you should go to the doctor. Because if you see type 1 with type 7, I know for sure that it is a hard poop in his gut. And it should remove, it should go out. What do we say about diarrhea? I took, because I'm from the Netherlands, I took the Dutch standard. Sorry, I can. So you see what it is? It is a usual defecation pattern is different, and you see that the amount of stool has increased and the stool contains more water than usual. This is diarrhea, but the overflow diarrhea is the type 1 and type 7 combined, and then you smell it really, really hard. So you should really go to the doctor. Right. Next slide. Yeah. So constipation, we have adults and we have children. The stool have less. Twice a week you should, as an adult, go to the toilet. You don't have to push. Then you see they feel likely not complete empty after pooping, but children and adults with Sanfilippo can't say that. But then you can look at, sometimes you can see in the baby, you can see when it is open and behind, then you know there is something nog in his gut. So this is also really good to know. Definition in children, you can see the poop is less than twice a week, is also the same. And what we see is there's a large palpable accumulation of stool in the abdomen or rectum. So you can really not give, it's really hard. Then you see the swallowing problems. Sofie already talked a lot. And here's what I said, reflux can damage to the esophagus, leading to esophageal scarring, which in turn can cause meningitis in a long term. So that's really important why you should treat reflux. Then there's malnutrition. And malnutrition occurs over the total body. And I can hopefully have the time to train you how we can discover malnutrition. So nutrition is always a challenge because you see in Sanfilippo insufficient daily intake, gastrointestinal problems, I already talked about it, dysphagia, teeth that are not fit this is also in other syndromes, that the teeth not always fitting each other, the right side, so then it's really hard to eat. Hand and mouth coordination when they are elderly, with the dementia, and also epilepsy. When they have an epilepsy seizure, you see that they eat less. Other nutrition related factors, the energy metabolism, as you are already saw, level of physical activities, then dementia, aspiration, and aspiration associated pneumonia. This costs also more energy. So if you have pneumonia, this costs a lot of energy. But what you also see in children with Sanfilippo is cognitive impairment, sensory disorders, so they are more hypersensitive. Medicines they have someone's relation that they can malnutrition, but for some that they are lonely when they are elderly, or the mobility can give some problems. So on the short term, when somebody is malnourished, you see the weight curve is downwards, and in the long term, you see the length curve is going downwards. What we also see, there's a reduced well-being, reduced resistance, increased risk of infections. You see just a lot of behavior problems, because if you have malnutrition and your body is needing for energy, they do the opposite in the beginning. They giving a lot of attention, and they have and a lot of concentration problems. So the behavioral problems and concentration problems could be also occur when somebody is malnourished. Depression, and we see that a lot also in us, as we have a lack of vitamin B12, and if we have a lack on vitamin D, fatigue, frequent crying, decreased fat mass loss, loss of muscle mass, slower recovery, complications in the disease and surgery, edema, disruption of metabolism, hypoglycemia, disruption of the endocrine system. But in the long term, we see reduced bone mass, so osteoporosis, development delay, extra, in Sanfilippo disease, decrease in muscle strength, and this is a problem, because if the muscles are going backwards, the recovery, if you are sick, will be longer. And also the heart is also, and the lungs are also muscles, so it is really good that you do training but eat well. Nutritional deficiencies with that problem, social isolation, because we see in families with children and adults with isolation, because of the behavior problem, they don't go out a lot of go eating with families. And this has not only something for the Sanfilippo patient, but also for his surroundings. Increased mortality and lethargia. So in the beginning, you see behavior problems, but after a long while, you see lethargia. And now I have a problem. Now it is 7 o'clock. And I have some other slides. So what I will do, I will share the slides with you, and then you can look to the slides if you want, and then you can see this. But I wanted to. So what I also do as a dietitian, when I shake your hand, I can see if you're malnourished. And this is, so you see my hand, you have here your thumb and you have here your right finger. But then if you look in the middle and you lay them on the table, and if you see this is flat or there is a lump in it, then somebody is malnourished. This is really easy because this is what I did seeing if children or adults with Sanfilippo. I looked always to the body because the body says a lot, and this is how you should look to it.
Okay. So thank you, Nolanda. We'll look through your slides, and if we have any questions.
Oh, that's so interesting. Thank you.
We'll write to you. It was a wonderful webinar. Thank you all for coming, for being present, and thank you, Sofie and Nolanda, for your presentation. And hope there will be chances to collaborate again in the future.
Yeah, we'll write to you if you got questions, because we might check the slides better. But thank you very much.
Yeah, and if you have questions, or maybe I can another have time to talk about nutrition, then we can do.
Okay, thank you.
Yeah.
Thank you very much.
Thank you.
So I
Thank
wish you
you.
all a good weekend, and thank you again.
Bye.
Bye.
Thank you. Bye bye.
Bye bye.
Thank you. Bye. Ma dovevamo essere così puntuali perché